Very good evening, boys and girls. So let's get started today. Another MCQ session on physiology, the NEET PG PYQs, and you know that we've considered many of the questions yesterday also. So in continuation, I'm going to take few more MCQs today. So I'm your mentor at Unacademy, Dr. Reena Kaur. So just before I start, just let me tell you that we are coming up with certain very interesting sessions in Unacademy. We've got the Unacademy previous year questions coming up, doubt clarification sessions and practice test also we are conducting. You can use the code REEP9 to avail all the benefits, additional benefits with Unacademy, and also to attend the special classes. Okay, so the first question for the day. Okay, so the first question for the day. Yes. Long acting calcium channels act in which part of the action potential? Long acting calcium channels act which part of the action potential? Anybody can just come up with the answer. So you know, because it is the long acting calcium channel, definitely we are speaking of the cardiac muscle, and especially because it is supposed to be the long acting, so we are supposed to be considered with the plateau potential, right? Yes, definitely it is going to be the phase 2 of the action potential of the ventricular cardiac muscle that is associated with the L type or the long acting calcium channel. So you can see that this is the cardiac action potentials which is seen in the ventricles, in the atria, and also in the SA node. These typically are your plateau potentials. This is the phase 0, which is depolarization, right? This depolarization is because of the sodium influx, as it is with the other tissues. Then you've got phase 1, which is supposed to be the initial rapid repolarization. Initial rapid repolarization, that is because of the opening of the potassium channels, resulting in the transient potassium efflux. But let me tell you that this efflux is not going to result in the complete or the final repolarization, because it is also associated with the opening of the L type, that is the long lasting calcium channels. So what are you doing is you are basically maintaining a balance between the outgoing potassium and the incoming calcium. So if the potassium is moving out, there is going to be complete repolarization. And if only the calcium is coming inside and inside, it would result in the form of a spike like this, isn't it? Spike. So neither we are getting a spike nor we are getting a repolarization. What we are getting is a plateau. So what is the cause of the plateau? The balancing between this efflux of potassium and the influx of calcium. Remember that this action potential is prolonged because of the plateau phase. Second very important thing is that the calcium which is coming during the plateau phase plays a very important role to bring about the calcium induced calcium release, right? A calcium induced calcium release, that is important to get more calcium from the sarcoplasmic stores, which are important for the cardiac muscle contraction. More the magnitude of this action potential, more is going to be the calcium influx, and more will be the release of the stored calcium, right? After phase 2, you have got phase 3, that is also called as your final repolarization, which is going to be accompanied by the closure of the calcium channels and the opening of the potassium channels with the potassium efflux. Then the phase 4, that is a resting membrane potential, and definitely you called it as a steady resting membrane potential. Why do you call it as a steady resting membrane potential? Because you want to differentiate it from an unsteady resting membrane potential that is of the SA node. So in the SA node, you are getting this unsteady resting membrane potential, which is actually the pacemaker potential, which is unstable, having a resting membrane potential between -55 to -65 millivolts. This unsteadiness or the instability is because of the natural leakiness for sodium, for potassium, the opening of the funny channels which allow the sodium during the diastolic repolarization and result in a spike. Very interestingly, you can see that the SA node do not show phase 1 and 2. So the phase 1 and 2 are absent in the SA node. You are getting depolarization and repolarization. Very interestingly, the depolarization is not because of sodium, but it is because of calcium influx, and repolarization, as in the other tissues, is because of the potassium efflux. So you can see that the ionic basis, the sodium influx during plateau, a balancing between the calcium and the potassium. Now this is one of the very important image based question that is associated with the pacemaker potential. You can see that this pacemaker potential का जो slope है, the slope is increased by the sympathetics. That means it is causing more acuteness in the angle of the slope, and therefore it is increasing the heart rate, whereas the parasympathetics are going to decrease the slope of the action potential, making it more obtuse and therefore decreasing the heart rate. So this is one of the very important image based question with the pacemaker potentials. Next one. A 60-year-old woman is a known case of hypertension for 25 years, and she has underwent a renal artery Doppler, which is showing a narrowing and turbulence in the right renal artery. If the radius of the artery is reduced by 1/3, the resistance will increase by how much? A, B, C, D. Yes. So it is simply based upon your relationship between the resistance and radius, that is the Poiseuille's law. So the correct answer is definitely D, that is 81. So you know that resistance is inversely proportional to 4th power of radius. Yes, very good dental clue. Very good. So in any case, when you are bringing about vasoconstriction, what you are doing is you are decreasing the radius. When you are decreasing the radius, you are increasing the resistance. So if it is 2 times, it will be 16. 3 will be 81 and 4 will be 256, right? Just to add to our knowledge, we must remember that this resistance blood vessels are your arterioles, your meta-arterioles, and also your pre-capillary sphincters. All these three have got rich sympathetic stimulation, right? On the other hand, remember that the capillaries have no sympathetic innervation. They don't have any sympathetic innervation. That means they could not alter their diameter. So the blood flow through the capillaries is modified only by the resistance of these blood vessels. So when I am saying resistance, that means it is playing a very important role in auto-regulation. And when I am saying auto-regulation, what am I doing? I am bringing about the auto-regulation of the blood flow, right? I am bringing about the auto-regulation of the blood flow. These arterioles are supposed to be the chief site of resistance because they have got large number of smooth muscle innervation and a very rich sympathetic innervation, and they play a very important role in contributing to the total peripheral resistance and therefore the diastolic blood pressure and your autoregulation of blood flow. So hemodynamics becomes one of the very important topic, right? Next one. The capillary and the interstitial hydrostatic pressures are 30 and 5. The colloid osmotic pressure of capillaries and interstitium are 25 and 5. what is the net filtration pressure? So this is very simple but very important. You know that the net filtration pressure is, you can just add up and subtract the values which are given to you. It is the hydrostatic pressure of the capillaries plus the interstitial fluid pressures minus the interstitial fluid hydrostatic pressure plus the colloid osmotic pressure of the capillaries. So all these values were provided to us and we got it as 5 mmHg. Now sometimes, you know, this question is tilted. Like you may be asked, you know that GFR is equal to net filtration pressures into your filtration coefficient. So this can be tilted. Suppose I am giving you that the filtration GFR is 140 ml per minute, right? And I can give you the values of these pressures. And I may ask you to calculate your KF. So in that case, you will have to do a double calculation. That means first find out the net filtration forces and then use it to find out the KF, that is the filtration coefficient that depends upon the hydraulic conductivity. Hydraulic conductivity, it depends upon the surface area of the capillaries and it also depends upon the permeability of the capillaries. And in any condition, if the KF is reduced, there is going to be a reduction in the filtration. Next. A patient presents with a right to left shunt. The oxygen content in the arterial and the venous side is 18 on the arterial and 14 on the venous per 100 ml respectively. The oxygen content at the pulmonary capillary is 20. What is the percentage shunting of the cardiac output? So I've taken lots of calculation based questions today because you know that you get lots of the calculation based questions also. Anybody would like to answer? 23%, 33%, 43% or 53%? Yes. So the correct answer is B, that is 33%. So we will just look into this. This is the normal atriovenous difference. That is around 20 ml of oxygen on the arterial side and 14 ml on the venous side, which comes to around 6 ml. In the condition that is given to us, the arterial given is 18, the venous given is 14 and we are getting the arteriovenous difference as 4 ml. That is 1/3 of the normal is reduced in the given. So if you are doing a 1/3 decrease, that it becomes 33% or approximately 2 ml. So again, the question is simple, but calculations are important. Coming on next with another calculation based question. The minute ventilation is defined as the amount of air breathed per minute. Okay? So which of the following is the correct formula to calculate the minute volume? Whether it is respiratory rate into tidal volume, respiratory rate divided by tidal volume, fraction of inspired oxygen by PEFR, or fraction of inspired oxygen divided by PEFR into R, that is the respiratory rate. So what is the correct formula? Anybody? Yes. So first of all, what is this minute volume? It is also called as the minute ventilation, right? It is also called as the minute ventilation. It is also called as the respiratory minute volume, right? So this is simply respiratory rate into tidal volume. Respiratory rate into tidal volume. Yes, Asmita, you are correct. So respiratory rate given 12, tidal volume given 500. This comes to around 6 liters per minute, right? But if the question is asking you alveolar ventilation, then it becomes different, because alveolar ventilation means the gas which is available only for exchange. So this will be your respiratory rate, that is 12 multiplied by tidal volume minus the dead space volume. That means 12 multiplied by 500 minus 150, that comes to around 4.2 liters per minute. So this alveolar ventilation is more important because every time we are breathing, 150 ml which is present in the anatomical dead space is not taking part in exchange of gases. Now, which of the following is or are correct regarding the role of Vasa recta? Regulating the tubulo-glomerular feedback mechanism, actively contributing to osmolarity, concentrating the urine, supplying the suprarenal blood flow, or sluggish blood flow. Yes. So remember that these vasa recta are present only in the juxtamedullary nephrons, which are around 15% of the total nephrons, right? These juxtamedullary nephrons have got a long loop of Henle, and their glomerulus is present at the junction of the cortex with the medulla. And instead of the peritubular capillaries, they have got the specialized vasa recta. These vasa recta are called as the counter current multipliers, right? They are called as the counter current multipliers. That means they are going to maintain the osmolarity. They are not going to contribute. They are going to maintain the osmolarity which is generated by, counter current exchange. I'm really sorry. This is the counter current exchanger, and counter current multiplier is your thick ascending limb of loop of Henle. So the osmolarity which is generated by the loop of Henle is being maintained by vasa recta. So definitely first correct answer is going to be C, that they help in concentrating urine. Apart from this, they are also responsible for the sluggishness of the blood flow in the medulla. Remember, active contribution will be your multiplier, that is your thick ascending limb of loop of Henle. Regulating the tubuloglomerular feedback mechanism. This is associated with your macula densa, which plays an important role in the regulation of GFR. So vasa recta, they are concentrating the urine and maintaining the sluggish blood flow. You know that the kidney has got a cortex and it has got a medulla. Around 95% of the blood flow of the kidney is towards the cortex, and the medulla receives only 2 to 5% of the blood flow. What is the advantage? This low blood flow prevents the dissipation of the solutes. That means whatever solutes you accumulated in the interstitium with the help of the thick ascending limb of the loop of Henle is maintained by the by the medulla, by the less medullary blood flow. So if you increase the medullary blood flow, they are going to be washed out. Yes, good one. Dental Q, if you've understood the concepts, it's really good. Next one. Now, what is dead space? It represents the volume of ventilated air that does not participate in the gas exchange. There are two types of dead space, you know. It is anatomical and physiological. What is the percentage of the normal dead space? 50 to 70, 10 to 20, 30 to 40, or 80 to 90. So remember that when we speak of the dead space, it is the exchange, it is the place where there is no exchange of gases. So one you have got is the anatomical dead space, which you called as your conducting zone. This conducting zone, which is from the 0 to the 16th generation of the airways, right? And the volume is 150 ml. Anatomical dead space can be deducted or can be measured by single breath nitrogen method. Single breath nitrogen technique, which is also called as the Fowler's method, right? When you come to the other dead space, this is your alveolar dead space. What is the alveolar dead space? That means any of the alveoli where the ventilation perfusion mismatch is going to be there. So if there is a mismatch in the alveolar ventilation, then it is going to be your alveolar dead space. But normally we do not have this. And if we speak of the physiological dead space, it is anatomical plus alveolar. Now because there is no alveolar dead space, I can say that in a normal person, the physiological dead space is actually equal to the anatomical dead space. We have no other dead space apart than the normal anatomical dead space. So you can say that in normal persons, the physiological dead space is equal to the anatomical dead space, right? And you can detect this physiological dead space by the Bohr's equation. Coming to the correct answer, it is 30 to 40%, right? So normal tidal volume is 500, out of which your dead space normally is 50 ml. That comes to around 30 to 40%. Yes, Hacker. Very good. So let the class be more interactive. It's really good, you know, that if you're making the class interactive, you are speaking in between. Next one. Which of the following statements regarding urea is correct or true? It is transported through aquaporins. It is reabsorbed in the proximal tubule. It has no role in the formation of concentrated urine, or the reabsorption is independent of ADH. Yes, who would like to make it A, B, C, D? Yes. So the correct answer is that it is reabsorbed in the PCT. No med. Reabsorption of urea, if you see, urea plays a very, very important role as a urea cycle for formation of a concentrated urine. It shows a passive reabsorption of around 50% in the PCT. It is very important to form concentrated urine. The urea is reabsorbed by UT, that is the urea transporters, which is an example of facilitated diffusion, which is enhanced by ADH, right? Which is enhanced by ADH. That means when the ADH is released, it is not only going to increase the water permeability in the collecting ducts and the DCT, it is also going to stimulate the facilitated diffusion of urea. So let me show you this beautiful picture of the urea recycling. Remember, urea is filtered and 50% of the urea is reabsorbed in the PCT. So it is only the PCT where you're going to get about 50% of reabsorption of the urea. After that, urea is not reabsorbed in any of the segments of the nephron unless it reaches the collecting ducts. From these collecting ducts, you will see that the urea is coming into the interstitium by facilitated diffusion through the urea transporters like ATA, UTA1, A3. All of them are facilitated by ADH. Once this urea comes into the interstitium, it will again move into the loop of Henle and it will be again recycled. So every time there is filtration of plasma, 50% is going to be reabsorbed in the PCT and the remaining 50% is going to be recycled again and again. Therefore, even if you are taking a high protein diet, then also your GFR increases. Moreover, when the kidney has to form a concentrated urine and there is increased level of ADH, ADH will not only reabsorb your water but also help in the facilitated diffusion of the urea cycle. Next one. Ultrafiltrate passes through all the filtration barrier except endothelial fenestra, basement membrane, fenestra in the podocytes, and the filtration slits between the podocytes. A, B, C, D. Yes. So definitely the correct answer is all except fenestra in the podocytes. Now this is the glomerular filtration barrier through which the substances have to pass, consisting of three important layers. First is the endothelial cell layer of the glomerular capillaries, a single layer of endothelial cells of the glomerular capillaries. Then you have got the basement membrane, and then you have got the visceral layer of the Bowman's capsule, which is going to form these foot processes or the filtration slits, right? This basement membrane has got negatively charged heparin sulfates, proteoglycans, which are going to be one of the most important barrier for filtration of negatively charged ions or proteins, right? So remember that this basement membrane has got negatively charged proteins like sialoproteins and heparin sulfate, but all the three layers are negatively charged. So please remember that though the negatively charged anions are present in the basement membrane, all the three layers are negatively charged. So the most effective barrier or the most effective substance which can pass through this barrier will be 4 to 6 nanometer, possibly a cation. The cation is going to pass more freely as compared to neutral, which is going to pass more freely as compared to an anion. So because it is negatively charged, the negative charge like proteins, and therefore the albumin is not freely filtered, and the best one is going to be a cation around 4 to 6 nanometers. Next one. What is Bowditch effect, which is also called as a Treppe phenomenon, a staircase phenomenon, or the frequency dependent activation? The basis of this phenomenon is associated with calcium handling. It involves the proteins that participate in the excitation contraction coupling like the circa. What is true about the Bowditch effect on heart? Increase in heart rate increases relaxation. Increase in heart rate decreases relaxation. Increase in heart rate increases contraction, or increase in heart rate decreases contraction. A, B, C, D. Yes. So it is increase in heart rate which increases the force of contraction. Here the ion responsible is calcium. This is also called as a force frequency relationship. A force frequency relationship. Right? Now, on the other hand, when we study the NRIP effect, what is this? This is increase in the force of contraction with increase in the afterload. Now, if you are asked regarding the Starling's law, this means increase in the force of contraction is directly proportional to the initial length of the cardiac muscle. Initial length of the cardiac muscle, right? Within physiological limits. Within physiological limits. This initial length means your venous return or your end diastolic volume. Med student, yes. B and C same. Yes, they are almost same, but I think best one would be again C, because it is related to the force of contraction also. If there is increased accumulation of calcium, then the force of contraction will also increase, and therefore the C goes to be the best one. Samjha? See, the strength of contraction is directly proportional to the amount of sarcoplasmic calcium. Right? Because यहाँ पर you are saying the force of contraction, therefore I would say to go best with the C. Now, insulin like growth factor 1 acts through which of the following receptors? Cytokine related receptor, G protein coupled receptor, nuclear or cytoplasmic receptor, JAK-STAT kinase, or whether it is tyrosine kinase. So what is the mechanism of action of the insulin like growth factor, which is also called as the somatomedin C, that is coming from the liver and potentiating the skeletal effects of your growth hormone? Yes, it is tyrosine kinase, right? So remember, the tyrosine kinase receptors are used by your nerve growth factors, insulin like growth factors and insulin, whereas the JAK-STAT kinase are used by the growth hormone and by the prolactin. So this mechanism of action of hormones itself is a very, very important and a repeatedly asked topic. Very good, Ashmita. You can classify the group 2 hormones. See, first is the group 1 hormones. These are all your lipid soluble hormones, right? Your lipid soluble hormones, that is the steroids and the thyroid, that are easily passing through the cell membrane, having intranuclear or intracytoplasmic receptors. The group 2 hormones basically are all the water soluble hormones. Water soluble hormones. Because they are water soluble, they cannot penetrate through the cell membrane, have their receptors on the cell membrane, and depending upon the second messenger they are used, they are categorized as A, B, C and D. A is using the second messenger cyclic AMP, B cyclic GMP, C calcium IP3 and D are using the enzyme link, that is kinases or phosphatases. Next, remember that hormones that uses tyrosine kinase are insulin like growth factor, vascular endothelial growth factor, hepatocyte growth factor and also the fibroblast growth factor. Yes. What is the false statement among the following about the funny current channels? It is sodium potassium ATPase pump. They are responsible for diastolic depolarization. It is responsible for spontaneous rhythm of the heart, and they are voltage dependent channel only. So what is the false statement? Yes, the false one is this, that it is a sodium potassium pump. Remember that these are funny channels, which are also called as the HCN channels, that is the hyperpolarization activated cyclic nucleotide channels, which are permeable to both sodium and potassium, but the permeability is more for sodium. Therefore, the sodium influx is much more, right? Apart from this, the natural leakiness for sodium and the calcium sparks, they all contribute to your pacemaker potential. Now, the mechanism responsible for the sustained vascular smooth muscle contraction is the sustained release of calcium from the Circa pump, vascular smooth muscle tone, latch bridge mechanism or the Henman principle. Yes, what is the correct answer? The correct answer is definitely the latch bridge mechanism. Okay, the correct answer is the latch bridge mechanism. Now you know that when you consider the smooth muscles, the first important thing is that in the smooth muscles, troponin C is absent. So instead of troponin C, the calcium binding protein which is present is calmodulin. So calcium is going to bind with calmodulin. That is going to activate the myosin light chain kinase, The myosin light chain kinase, when phosphorylated, when activated, will cause phosphorylation of myosin. And after phosphorylation of myosin, there is going to be the formation of the cross bridges between actin and myosin. Now, in the smooth muscles, there are two important enzymes. One is the myosin light chain kinase, that is for your contraction, and the other is the myosin phosphatase, that is responsible for your relaxation. The enzyme activity of the two will depend upon the level of the calcium concentration, right? So high concentration will activate the myosin light chain kinase, and the low concentration will activate the myosin phosphatase. So this cross bridge activity, that is attachment detachment, attachment detachment, takes place very slow in the smooth muscles, because this activation and deactivation of the enzymes is slow. That means what? That means the time for which the actin remains bounded to myosin, the time for which the actin remains bounded to myosin will be more. And you know that more the actin remain bounded to myosin, more is going to be development of the active tension. So this is what is actually the latch mechanism, and because of this, the smooth muscles have got more force of contraction. They are doing more work with less consumption of energy. With less consumption of energy. Because more you do your attachment detachment, more you're going to break down, more you're going to form, the number of ATP required will be more. But yahan pe the time for which they remain attached to each other is more. That is what is called as the latch mechanism. Which of the following is correct? Let me just skip this question. Yes. The following graph, so this is the graph. Oh God, the graph is absent. I'll draw this. So this is the hysteresis loop the question is about. This is inspiration and this is your expiration. So we are speaking about this hysteresis loop. Now the graph is showing a relation between the lung volume and the intrapleural pressure changes during inspiration and expiration. What is the likely cause over here? In the initial part especially, due to a difference in active and passive work during inspiration, respiration, due to difference in surfactant during inspiration and expiration, due to difference in the airway resistance during inspiration and expiration, or difference in the intrapleural pressures. Yes. Yes. So the correct answer is B. So at the start of inspiration, the alveoli are small, the surfactant is concentrated, resulting in the decrease in the surface tension. At this point, only a small change in pressure and the volume increase will be significant, and the lungs will keep on distending, the surfactant will be scattered, the surface tension will be more. Okay, the surface tension will be more, right? That means if you see the initial part, that means this part, more work has to be done by the lungs to overcome the surface tension forces, to overcome the surface tension forces, right? And if you consider inspiration and if you consider expiration, in inspiration the surfactant molecules are separated far apart from each other. During expiration, these molecules, they come close to each other. That means the surface tension is also depending upon the surface area per unit that is covered by the surfactant. And you can see that the surface tension reducing effect of the surfactant is much more during expiration than during inspiration, because during expiration the molecules of the surfactant are quite close to each other. Next one. Which of the following reflex describes increase in the heart rate with atrial distension? Frank-Starling, brain bridge, vago-vagal reflex, or whether it is your Bizol-Jarisch reflex? A, B, C, D. Yes. So you know that whenever there is increase in the venous return to heart, there is going to be the stretching of the SA node. This stretching of the SA node is going to result in increase in the heart rate. This is what is called as your brain bridge reflex. Any advantage of this? Yes. The advantage is that the increase in the heart rate will cause increase in the cardiac output. That means you are also going to increase your GFR. This is also going to result in water loss, or that is diuresis. Apart from this, whenever there is increase in the atrial distension due to increase in the venous return, there develops another important reflex that you called as the volume reflex, wherein there is increase in the atrial natriuretic peptide from the left atrium, which is going to cause relaxation of the mesangial cells in the glomeruli. It is going to cause the dilatation of the afferent arterioles. These effects are going to cause increase in the GFR, which therefore helps in natriuresis and diuresis. At the same time, there's going to be decrease in the level of ADH, so that you also decrease the reabsorption of water. The Frank-Starling law is what? The Frank-Starling law is the same, that within physiological limits, if you increase the venous return to the heart, that means if you increase the end diastolic volume, which is called as the initial length, there is going to be increase in the force of contraction. Now, absolute refractoriness of a neuron is because of A, closure of the activation gates of sodium channels, closure of the inactivation gates of the sodium channels, hyperpolarization of the chloride channels, or closure of the potassium channels. What is the cause of the absolute refractory period of the neuron? Yes, it is because of the closure of the inactivation gates of the sodium channels. We'll just look into this diagram. You can see that the sodium channels have got two gates. On the outer side there is the activation gate, on the inner side there is the inactivation gate. Remember, these inactivation gates are more important in regulating the sodium entry into the cells. Right? They are more important. So, at the resting membrane potential, that is minus 90, the cells are supposed to be ready. Ready for what? They are ready that if a threshold or a suprathreshold stimuli is given, the activation gates will open and the sodium will enter. So remember what is occurring. What is occurring? That at the resting membrane potential of minus 90, the cell channels are ready. That means if you give a threshold or a suprathreshold stimuli, the activation gates which were closed will open and the sodium will enter. And you're going to get this upstroke which we call depolarization. That is plus 35 and this is minus 90. Now in the absolute refractory period, what happens that even though if the activation gates are open, the inactivation gates, they close. That means now even if you are giving a suprathreshold stimuli, the inactivation gates are not going to come out of their resting stage, right? So inactivation gates are more important. If the inactivation gates are closed, if they are not recovered, whatever may be the strength of stimulus, never the activation gates can allow sodium. Now, when the membrane is going to be repolarized and come back to its resting membrane potential of -90, the inactivation gates will again reset themselves. Reset means what? They will open and the activation gates will close. And again the membrane will be responsible for the second stimuli, right? So in one word we can remember that the activation gates are always active, but their activity is not so important in regulating the sodium entry. It is the gate which is important, is the inactivation gate. Now, which part of the kidney is called as the diluting segment of the kidney? Whether it is PCT, the ascending limb of the loop of Henle, the descending limb of the loop of Henle, or the collecting ducts. A, B, C, D. So for this we will just look into the nephron. This is the nephron. This is my PCT, which is going to be continued as the loop of Henle, and the loop of Henle is going to be the collecting ducts now, from the DCT to the collecting ducts. So what is the normal feature? Now see, you've learned that in PCT there is fluid which is isotonic. That means isotonic, that means having osmolarity same as that of plasma. What is the reason? See, there is going to be presence of water and there is going to be presence of solutes, right? But in the PCT there is an equal reabsorption of solutes and water. There is an equal reabsorption of solutes and water. Therefore, the tonicity is isotonic. When this is going to come in the thin descending limb of the loop of Henle, water will be reabsorbed more and more, because the descending limb of the loop of Henle is highly permeable to water. So it reabsorbs the water, and what will remain inside will be the solutes and solutes. So this is going to be hypertonic as compared to plasma. Now this, when reaches the thick ascending limb of the loop of Henle, the ascending limb reabsorbs your solutes. Why? Because this segment is supposed to be totally impermeable to water. This is impermeable to water. The thick ascending limb of the loop of Henle is impermeable to water. The tonicity of the fluid there is hypotonic, and therefore it is called as the diluting segment of the nephron, right? So you know, when we say this is an obligatory phenomenon: isotonic, hypertonic, hypotonic. What is the concept? What is reabsorbed more? Like in the PCT, equal reabsorption. In the descending limb, solutes are remaining behind, water is reabsorbed. In the ascending limb, water is remaining behind and the solutes are reabsorbed. So this is an obligatory phenomenon, and after this, from here, the tonicity of the urine will be totally depending upon ADH. So if the ADH is present, a small volume of a concentrated urine. If ADH is absent, a small volume of a large volume of a dilute urine will be there. Next one. How would you differ an electrical synapse from a chemical synapse? No cytoplasmic continuity between the presynaptic postsynaptic neuron, unidirectional flow of impulses, connexons are involved in the electrical synapse, and the electrical synapse has more latent period than the chemical synapse. A, B, C, D. Yes. So correct answer is connexons. You can see that this is a chemical synapse which is very much similar to the neuromuscular junction, showing a one-way conduction, one-way conduction. Why? Because the neurotransmitters are secreted from the presynaptic junction, from the presynaptic neuron. They are acting on the receptors on the postsynaptic neuron, whereas the electrical synapses are communicated to each other through cytoplasmic channels, that is the gap junctions. And you know that the gap junctions are made up of subunits that are called as connexons. Now, because in the chemical synapse you use a neurotransmitter, on repeated stimulation you can produce a fatigue, which is not seen in the electrical synapse. Very important thing, the chemical synapses, they show what is called as the synaptic plasticity. That means the strengthening of the synapse, for example in your memory and learning, is done by the chemical and not by the electrical synapse. Now, the rate of absorption of a drug taken orally is found to increase as the dose ingested is increased up to a point where further increase in the dose results in no further increase in the rate of absorption. The absorption does not appear to result in splitting of ATP. Does not. That means no ATP is used. What is the process of this drug absorption? Facilitated diffusion, primary active transport, restricted diffusion, secondary active transport, or a simple diffusion. A, B, C, D. Yes, anybody would like to make this answer? It is simple but a very, very important conceptual topic for us. And you know that the general physiology wala part is really important. So what clue is given to us over here? The clue that is given to us is ATP is not used, but there is a use of a carrier protein which is showing saturation. So all these features, they go with our facilitated diffusion. Right, all these features, they go with our facilitated diffusion. Therefore the correct answer is your facilitated diffusion. See, this is the typical facilitated diffusion where the binding of the molecule is simply going to result in a conformational change that will allow the substance to come to the interior, and then the carrier protein will be again recycled. Right, so the only thing that is occurring is a conformational change. It is moving along its concentration gradient from high to low, but there is no use of energy. Remember that if you compare your simple diffusion with your facilitated diffusion, this one is faster. Right, so simple and facilitated, these don't use energy. They are also called as downhill passive transports. Next one. A 58-year-old woman with a history of substernal chest pain with heartburn, and she has been taking omeprazole, and a conventional esophageal manometry is done. Which of the following is the cause of relaxation of the lower esophageal sphincter in response to swallowing? So a very typical INI-CET type of a question where you are getting a clinical scene, but what I am interested is simply the one line physiological answer. Right? So what is responsible for that? Circulating gastrin, inhibitory sympathetic nerve input to the lower esophageal sphincter, intrinsic myogenic tone of the circular smooth muscle, release of acetylcholine from the myenteric plexus, or release of VIP and nitric oxide from the inhibitory ganglionic neurons. A, B, C, D, E. Yes, so the correct answer is E. So you know that whenever we speak of this relaxations in the GIT, the relaxation in the GIT is caused by peptidergic fibers that secrete VIP. right? So what happens between the meal? What happens between the meal and what happens? Uh, what happens between the meal and what happens during meal? So remember that between the meals, the esophageal sphincters are tight or the tone is maintained, right? The tone is maintained. But when you are swallowing, you want that there should be relaxation of the sphincters. There should be relaxation of the sphincters. This relaxation of the sphincter is very much mandatory. Why? Why should be the relaxation of the sphincters? See, this is your esophagus. This is the upper esophageal sphincter and you've got the lower esophageal sphincter. So this lower esophageal sphincter must relax so that the food can enter into the stomach, right? The food can enter into the stomach. In between the meals, this is in between the meals, okay, in between the meals, the lower esophageal sphincter tone is kept high. Just 1 minute. Right? In between the meals, the lower esophageal sphincter ka jo tone hai, it is maintained, because if the tone is not maintained, there is going to be the regurgitation and the patient is likely to develop the reflux. Whereas if there is failure of relaxing, low control and skilled movements, motor muscle fibers are present, there is increased precision of movements or none of them. So what is the correct one over here? What is homunculus? If you remember, homunculus is the ugly representation of the human body or the human parts in the brain. You know that the presentation depends upon how skilled the movements are performed or how much is the sensory involvement of that area. So it basically depends upon the precision of the movements, right? So in the case of motor homunculus, it is the increased precision of the movements. That means those areas which have to do fine motor activities, like the muscles for the speech and the thumb, right? The muscles for the speech and the thumb, they are going to have maximum area for representation. So you can see over here, this is the typical motor homunculus. The facial region and the thumbs have got maximum presentation, and also same is going to be in the case of sensory. Sensory may be aise yoga. Those areas like the facial regions and the thumb which have got more sensory innervations are going to have more area of representation. Climbing fibers are excitatory too. Stellate cells, ganglion cells, granule, Golgi or the Purkinje cells. A, B, C, D. Yes, we know that the climbing fibers are stimulatory to the Purkinje cells. So you can see the circuitry of the cerebellum where there are mossy fibers and there are climbing fibers. The mossy fibers, they are also stimulatory to the Purkinje. The climbing fibers have got one-to-one relationship and they are also stimulating the Purkinje. Mossy fibers who stimulate the granule cells. The granule cells, they give the parallel fibers. But the Golgi cells, the basket cells, they all inhibit the Purkinje cells. This is typically an example of feed-forward inhibition which is seen in the cerebellum. And remember that the Purkinje cells are the only output from the cerebellum to the deep cerebellar nuclei, which is inhibitory. But the final output from the cerebellum, going out from the cerebellum, is always going to be excitatory, right? So I hope, boys and girls, that today's session was very effective to you. You've learned through this session. So I think with this we sign out for today's session, and again tomorrow I'll be taking another important session, right? I'll be taking either some important topics for INI-CET with few MCQs, or again I'll be taking a NEET PG MCQ session. And if you've got any suggestions, you can always come to me. Thank you for your patient learning and listening, and I wish all of you a very, very best of luck for your studies. You're passing through one of the toughest period of your time. Just believe that you can fly if you give out your wings. So self-confidence, persistence and faith what is needed. Okay, so bye bye everyone. Thank you. Take care of yourself. Happy learning always. Bye bye.